And with that, I'll transition to our next speaker, another one of our Hoag nurses, Jessica Hovland, who was for 9 years a PACU, or recovery room nurse, who's just about to finish up her doctorate of nursing practice, and has chosen this project on using virtual reality in the PACU to try to limit opioid usage. Jess, we're happy to have you here with us, and take it away.
Hi, Dr. Lewis. Thank you so much. I am honored to be here today, and I'm excited to share with everyone about my DNP project. It's been one heck of a journey over the last year, especially with COVID, trying to derail my elective surgeries in the middle of it, but we were able to bounce back from that, and here we are today to talk about everything that happened. So today, this is my DNP project. This is a multimodal analgesic virtual reality program to reduce initial opioid exposure and usage. Next slide. My name is Jessica Hovland. I am currently in my DNP program, like Dr. Lewis had mentioned. I will be graduating in December. Hopefully, I'm on the right track. So, and I will be graduating with an emphasis in nurse executive leadership. I'm currently a student at the University of St. Augustine for Health Sciences. Unfortunately, I used to work for Hoag. I was there with my family, my Hoag family, for almost 9 years, and I miss them greatly. But now I am the assistant and interim clinical director at Del Medical School's UT Health Austin Ambulatory Surgery Center, and I've been here for 3 weeks. So next slide. So here's the purpose and the background of my project. For my DNP project, I had to create some type of evidence-based practice change in the clinical setting. And back in September, Dr. Lewis and I had attended a wedding and started brainstorming, and that's where this whole idea for this project began. We decided to collaborate and bring VR to the nursing bedside in the perioperative setting. Then I just started doing some research on VR, started to learn more about it, and I realized what a big impact it would have on our society's opioid crisis because of its pain management like interventions. And so this is my standard practice that I want to integrate, and it's to provide more non-opioid approaches. So looking back, some of the people that I have to thank: Dr. Robert Lewis obviously was my VR project sponsor and mentor. Dr. Chet McCauley has been my preceptor for the last year. Dr. Kathleen Farrell has been my faculty that has helped me write my proposal. Dr. Alam Jadala was my go-to nursing researcher. Dr. Justin Bush, my anesthesia champion, who helped me create the program and its protocols, and then all of my nursing leadership in the perioperative setting. And I forgot to put Shannon Watanabe, number one. She's the executive director of Periop, Jennifer Bunting, my PACU manager, Rebecca Moore, the pre-op manager, and Diane Amaral, the OR manager. And of course, I can't forget to thank both Robert Braithwaite and Rick Martin for granting me approval to proceed with this project. Next slide. So let's go back into history. I'll talk about the opioid epidemic, kind of give you a reason why this project is so big right now. Back in the 1970s is when federal involvement in combating the national opioid crisis began. And this is when the Controlled Substances Act was first passed and required federal regulation of controlled substances. Then in the 1990s, there was this detrimental evolution. The Joint Commission and Centers for Medicaid and Medicare started to tether patient satisfaction to the amount of times that clinicians were providing pain management interventions, and that was on their patient satisfaction survey. And then in 1991 to 2013, the number of prescribed medication increased from 76 to 97 million. And this was also caused by the FDA's release of OxyContin. The manufacturers of OxyContin started to aggressively market this to physicians and released information about it, saying that there was a low risk for iatrogenic addiction, which obviously we know is false. It wasn't until 2010 when the Affordable Care Act and the Department of Health and Human Services declared pain as a public health concern. And then in December 2015, there were some clinical practice guidelines that were released from a number of different societies, including the American Pain Society and the American Society of Regional Anesthesia. And some of the strong recommendations included providing patient and family-centered preoperative education and planning, provision of multimodal therapies, and utilizing oral opioids versus IV opioids to manage pain because of their superior effects on postoperative pain. Next slide. So why does this pertain to peri-op? 10% of opioid-naive patients undergoing same-day surgery who were given a low dose of opioid prescription for pain were identified as long-term opioid users after 1 year. Therefore, limiting the exposure during the immediate postoperative period may impact patient opioid usage in the long run. About 80% of our heroin abusers' habits stem from opioids prescribed by doctors, and about 130 Americans die from an opioid overdose daily. In 2015, over 11.4 million people abused their opioid prescriptions, and interestingly, in California, the majority of opioid-related deaths are from prescription opioids compared to synthetic opioids or heroin. If you look at it from a different perspective, one study found that gynecologists prescribe 2 times the amount of opioids than the average consumption after a hysterectomy procedure, and cite multifactorial reasons for their practice, such as patient satisfaction and reduction of postoperative calls. And then patients undergoing laparoscopic hysterectomies typically experience the most intense pain in about 30 minutes after surgery. However, we've transitioned over to a robotic approach recently, and that has been the surgical standard. Unfortunately, despite significant improvement with our robotic approaches, morphine consumption remained the same in the recovery room in one study. And this suggests that opioid-centric clinician culture persists despite improved outcomes. Next slide. To really create this project that could have a big impact in the perioperative setting, and I decided to combine and blend 2 evidence-based practices, both multimodal analgesia and virtual reality, and created one program that had elements of both of these. So my PICO question for my DNP project was, will initiating a multimodal analgesic virtual reality program compared to current practice decrease opioid requirements in robotic hysterectomy patients during the postoperative period? And I chose the robotic hysterectomy patients because I found that when I did a practice gap analysis, they were the second highest consumers of opioids compared to the number 1, which was our neurosurgical patients. They were the second highest consumers of opioids in our PACU. Next slide. Here's my framework that I used to create the program. The model for improvement was my framework. And the model for improvement is comprised of 3 questions. What are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in an improvement? So my answer to the first question is, by providing virtual reality and multimodal analgesia as non-pharmacological interventions, can nurses decrease opioid exposure by 10%? The answer to the second question is that my goal was that this project would need to show a decrease in opioid administration and an increase in multimodal techniques to benefit our patients' surgical experience. And then the answer to the last question is basically focusing on a specific patient population that would benefit the most from this program, and that was the robotic hysterectomy population. I also used Everett Rogers' diffusion of change theory to help me understand how to integrate a new technology at the clinical bedside. And this theory describes the process of adopting innovations in a healthcare setting And they defined diffusion as a social process amongst organizational stakeholders resultant of an evidence-based innovative change. And basically, in a nutshell, if the providers believe in the technology and if they are provided the correct education and knowledge, they will stick to the plan and implement it, and this will happen. However, if their values do not align with the adoption, this will happen, but then it will start to drop off. And so I spent a lot of time creating the education that was needed, communicating with different stakeholders amongst different departments. We went to anesthesia, we went to the surgeons, we went to the nurses. And so everyone within the hospital setting was involved in this. Next slide, please. Here is my DMP project timeline. Technically, it started in September when Dr. Lewis and I went to that wedding, but the formal planning started in October. That is when the PDSA cycle started. All of the planning for the project began and went until March. In April, I submitted my application to an IRB, which was the St. Joseph and Hoag Hospital IRB. I got approval in May 2020 from the IRB, as well as from my university's Evidence-Based Practice Review Council. Then in June 2020 is when we started all of the in-services and nursing education for the program. From June to July 2020 is when we did full implementation of the program. And right now I'm currently in the ACT stage where I'm currently completing all the statistical analyses and completing the project proposal and getting it ready for publishing. And next slide. So here are some of my team members that I owe so much to. These are my 4 East nursing VR champions. They took on these roles during COVID when their unit was closed. And so they helped me during the nursing education portion of the program. The first 2 are Sarah and Alana, and on the right are Tara and Anne. Man, I could not have done this without them. They were with me for a whole week. We went to about 300 different nurses, a handful of different surgeons, and just I originally wanted to get to all the anesthesiologists. I think there were about 50 anesthesiologists that we tried to get. We didn't get all of them, but just imagine putting VR headsets on all of those people. It was fun, and it was we wanted to get to everyone, so it was definitely challenging as well. Next slide. Here is our VR setup in our pre-op and our PACU. This is what the nurses, they would go into their medication room, and it was a locked room, so we made sure that these headsets would not walk away. The clean box technology was what we used to clean them. So they would sit in this box for about a minute under UV light technology after being sandy wiped down. And before I forget to mention, we use the applied VR headsets and all of their programming in order to provide all of the VR simulations. Next slide. Here is a picture of Dr. Lewis and our OR team. We got together at 7 in the morning and provided education to them. You'll start to see different people in blue. All of the people in blue are nurses, and they're from 3 different departments. We reached the pre-op area, the OR area, and the PACU area, because those 3 departments were kind of the glue to making sure that this program was successful. I have Dr. Wang, one of our general surgeons, in the top right, and then Jennifer Bunting, my PACU manager, at the bottom. Next slide. And this is just, this slide just shows you how much was put into this program, and people took time out of their days to trial this amazing product that we were providing to our patients. So just various different stakeholders involved. Next slide. Here's a little video that.
Oh wow, the boat is really big.
And pre-op.
Here he comes, turtles.
There's another reason why he was on. That's so funny.
It was just so funny to watch them all.
That is crazy.
And imagine being drugged up doing that.
Yeah.
Oh man, they had a blast. So here are some of the results, and I don't want to belabor too much on some of the extraneous variables, and I'll get to the ones that really made an impact. So if you can see there on the right side, I wish I would have highlighted the entire yes and no area. So starting at the top there, most of my patients went into their procedures with low pain, and all of the patients came out with low pain as well. So, and this was for the pre and post implementation groups. So we did a great job there. And then on the second line there on the right, the multimodal analgesia administered in pre-op. As you can see in the pre-implementation group, about 67% of them did not receive any type of multimodal analgesia in pre-op. And I'm talking about at least 2 oral medications. So Robaxin, Mobic, Tylenol, those types of medications, they had to have at least 2 given in pre-op. And as you can see here, after the program was implemented, 100% of the patients received those medications. And then you can go to the next slide. I have some data here on the lengths of stay in PACU, as well as the amount of time that the VR headsets were worn. But the number one primary variable that I want to focus on is the opioid consumption converted as morphine milligram equivalents in the PACU. In the pre-implementation group, the mean total opioid consumption was 20.52, and in the post-implementation, it was 21. So unfortunately, there wasn't a statistically significant difference, and unfortunately, it was a little bit more after the program was implemented. But I will show you something that will pique your interest here in a little bit. So we'll get to that. Go ahead and we didn't get to all of the sample size that we wanted to, mainly because of COVID. We weren't doing, as many robotic hysterectomy procedures after COVID hit. We did this around June to July. So it was just picking back up and getting into the groove of things after COVID had shut down all of the elective surgeries. So here are some of the implications that we learned during the project. All of the nurses now have so much knowledge about the non-opioid approaches, both multimodal analgesia and VR. They started getting more familiar with the technology. I mean, they had to learn every single simulation within the applied VR program in order to kind of tell their patients, hey, you should probably go swim with some whales, or hey, why don't you go take a trip to France? And so they knew it before or after all of the training. Unfortunately, 27 patients refused the VR in PACU for various reasons, and some of them included lethargy. They were just so tired. They didn't want to try on the headset after having the surgery and having anesthesia. Some of them did complain of nausea, so we immediately took it off if they started feeling dizzy or sick. And then some didn't feel like having a VR headset on after surgery. So what the most interesting part of that was, the patients who did refuse the VR, they did get the multimodal analgesia in the pre-op area. And so as you can see in the bottom of my table here, the mean opioid consumption for the refused VR group was 13.59, which is almost half of what the pre-implementation group, what their average was. So based on this project, I think multimodal analgesia should be a standard practice. I think we should start thinking about, go back a little bit. There we go. We should reconsider utilizing VR in another perioperative area. So maybe not in PACU, but maybe more so in pre-op is where this VR headset should be used, because what my pre-op nurses were telling me was that they started using it during their IV starts, and it would just soothe the patient's anxiety. They felt more ready and calm when the surgeon came to talk to them. So these are some of the things that I think we should start thinking about for phase 2 of this project. Okay, you can go to the next slide. So in conclusion, we didn't produce a statistically significant difference in the total opioid consumption. However, now again, we're using more, we have the VR headsets in PACU. We also have them in pre-op now. So that is a tool for the nurses, and they're more aware of all of these non-opioid approaches. The clinical staff was so impressed with the VR technology. They even started taking the VR headsets for themselves. And it's so funny that the first presentation was on VR burnout, because whenever they had a long day or they just wanted to relax, some of them wanted to just even take it on their breaks and just use it for themselves. So there was a lot of good feedback on that. Again, multimodal analgesia should be standard practice. We need to explore more why our patients were refusing the VR. Did it happen? Was our anesthesia practice the same? Were we also considering the fact that they were getting pre-op medications and then tailoring our anesthesia medications intraoperatively as well as in PACU? I also think that the PACU nurses need to more focus on giving more oral opioids. Traditionally, more IV opioids are given in PACU, and so we can revisit that practice. So VR should be incorporated in other areas of the perioperative setting, like I said, in pre-op, maybe even using it in lieu of Versed, using that to take the patient back into the OR would be an awesome project. Next. Unfortunately, I didn't bring all my references, so if you need my reference list, I have it. Please email me. I am available. Please let me know if you have any questions. I can't stop talking about this project and how fun it was to implement at Hoag and how enjoyable it was for all the staff. So thank you, Dr. Lewis. Thank you for having me here today, and to everyone who has helped on this project.